Good afternoon. Pleasure to be here, even if it's remotely. We're going to talk about pancreatic cysts, and we're going to first mention how common they are, how to make a differential diagnosis, and how to manage patients with IPMN, which really constitute the majority of pancreatic cysts that a clinician sees in the practice. So how common are pancreatic cysts? If we look at CT or MRI findings just randomly, 3 to 13% of patients will have a cystic lesion in the pancreas. And if we look at autopsy studies, these are also very common. And of course, as we become older, they're even more common. But the most interesting study on this, actually quite revealing, was published in Gut now a few years ago. And this is an interesting study coming from Germany, where they did MRIs on healthy patients. And they did the study over 5 years, analyzed over 1,000 patients, 670 underwent an MRI, and they found a lot of pancreatic cysts. Well, the prevalence of pancreatic cysts was almost 50%. The weighted 5-year incidence was 12.9. Now, these cysts are small, on average 5 millimeters. And as you can see there, a small proportion of them are larger than 1 centimeter, and an even smaller proportion are over 2 centimeters, only 0.6%. But these small cysts, which we as clinicians are seeing a lot in our offices, we get e-consults or we see the patients in the office, they're freaking out because they had this 7-millimeter cyst in the pancreas. As you can see, you can tell they're in very good company. Here you see the prevalence adjusted by age, and as we get older, this prevalence increases. It's easy to remember, by decade, 60 years old, 60%, 70 years old, almost 70%, and so forth. And the size also increases with age to the point that it was, 5 millimeters is what I said around age 60. But as you keep on increasing in age, the size also increases. So take back messages, small cysts, they're not just they're very, very common. And this is interesting because we also see CAT scans, and patients have liver cysts and they have kidney cysts. We don't even, yawn over them at all. And yet we're getting very concerned about pancreatic cysts. However, cysts more than 1 centimeter, that's only 1 of every 40 persons, and cysts over 2 centimeters, 1 out of every 300 persons. So what are these pancreatic cysts? This is not a representative sample for the general population, but a representative sample from surgical series. This is a series that we published a couple of years ago. It's almost 1,300 pancreatic cysts, and you can see there by size, the most common by far is IPMN, followed by mucinous cystic neoplasm, followed by serocystadenoma and cystic pancreatic neuroendocrine tumors. However, there are about 20 different possibilities, so about 20 in the differential diagnosis of a pancreatic cyst still. However, the overwhelming majority is going to be an IPMN. And here we see the distribution by decades, and as you can see now, this has changed, and most of the cysts that we resect nowadays, more than almost 60%, are IPMNs, followed by mucinous cystic neoplasms, by serocystatinomas, cystic neuroendocrine tumors, and then solid pseudopapillary neoplasms, and then a great variety of other cysts. So let's start talking here of one of the 3 most common, which is a serocystadenoma. Serocystadenoma is a cystic lesion that occurs mostly in females. 3/4 are women. Mean age is 62. It can be located anywhere in the pancreas and can be microcystic, and I will show you some examples, but can also be macrocystic and even appear to be solid on imaging. The majority of times, these are incidental findings. However, a small percent can have biliopancreatic symptoms. They can have obstruction of the pancreatic duct. Perhaps a few of them can present with pancreatitis. They can have bile duct obstruction. And interestingly, can be a palpable mass on physical exam. The important take-home message is this is a completely benign and slow-growing tumor. Here you see an example of a fairly large one in the head of the pancreas, very typical appearance. In fact, it doesn't look cystic here. It looks more like a spongy lesion with a central scar. Here you see what it looks like once the specimen is out and taking a photograph. It looks like a honeycomb, very small cyst. And these cysts are filled with clear fluid that is glycogen rich. This is a typical serocystadenoma, And if a radiologist or a clinician sees this, they can make the diagnosis just based on appearance with this central scar and this microcystic appearance. However, this one here in a woman who was 45 years old, well, this doesn't look like a serocystic adenoma. You can say, well, this is a mucinocystic neoplasm or perhaps an IPMN or something else. And yet, this is also a serocystic adenoma. It's an oligocystic serocystic adenoma. These are tumors that should be managed expectantly, and most of these will be small. They're causing no symptoms. However, in patients who are reasonable operative candidates that have symptoms, or where we cannot definitively exclude a malignant or potentially malignant tumor, or who have large tumors and a long life expectancy, we should be offering resection. So here's an example, and you can see this is a woman that I saw, a few years ago, and she came to see me with this very, very large cyst in the head of the pancreas. And you can see here that she already had a stent. She had presented to her outside gastroenterologist with jaundice, and they managed to put a stent through the papilla and relieve the jaundice. And she came to see me with this very large mass, which interestingly had been identified 10 years prior. At that time, it was not as large. It was not causing bile duct obstruction, but she was told she had a benign tumor and not to worry. But now she's in her 70s, and now this is a problem because it's causing jaundice. And obviously, it's not just a problem for the patient, but also for the surgeon, because operating on this is a lot more complicated, as in fact it was. This patient had a certain vascular anomalies that made it a little bit more complex. And you can see here the large tumor, and this patient did well, but it's not always possible to do these operations. So if we're seeing a large tumor, I think the clinician should follow it and be sure that it's not growing at a high pace. And if the patient's life expectancy is good, it's sometimes better to be proactive, even if it requires, like in this case, a Whipple procedure, rather than to wait until the tumor is so large that it makes the operation a lot more complex. The second tumor I would like to talk about today is a mucinocystic neoplasm. This is a tumor that has an interesting epidemiology because it's seen almost exclusively in women. In fact, in middle-aged women. And also almost exclusively seen in the body and tail of the pancreas. As you can see in this slide, more than 95% are women, more than 95% are located in the body and tail of the pancreas. This helps when you're seeing a lesion in this location and in this gender, and you can sort of anticipate just by radiology to make the diagnosis. The majority of these patients, not unexpectedly, are asymptomatic because you got a lesion in the body and tail of the pancreas. It causes no pain, sometimes a little bit of weight loss, sometimes rarely, not commonly, a palpable mass. Unlike serocystic adenoma, this is a tumor that does have malignant potential. And at the time that we resect them, 18% already have carcinoma, 10% are considered borderline, and the rest are adenomas. That doesn't mean that if left to their own, these adenomas would become malignant over time, but of course it can take a long time. This is also a malignant neoplasm of the pancreas that has excellent prognosis, unless the carcinoma has already had transmural invasion. Here you're seeing two examples, this one in the tail, and you can see a thick wall cyst. This is filled with thick mucin. You can see that it has a nodule. In this case, well, maybe they resected too much pancreas and they should have resected less pancreas. In this other example, is also a mucinocystic neoplasm, but it's a little different because it has a lot of septations, a lot of compartments, again, filled with thick mucus. Here's another example, and I bring this one up because this was a young woman, so she was not the typical mucinocystic neoplasm. She was a woman in her late 20s, and she presented with this cystic lesion to the emergency room with abdominal pain. Of note is that the initial diagnosis, oh, this patient has a pancreatic pseudocyst, but, more savvy radiologists and clinicians would say, well, this doesn't really look like a pseudocyst. I'm not seeing a lot of inflammation in the pancreas. I'm seeing some septations within it. This doesn't look like a pancreatic pseudocyst, and certainly should not be treated as a pancreatic pseudocyst, which would be draining, very tempting here just to the stomach. On endoscopic ultrasound, you can see a very unusual appearance for a pseudocyst and more consistent with a neoplastic cyst. You can actually see a big thick nodule, and here you can see the specimen, the thick nodule, and this was a mucinocystic neoplasm in a 28-year-old. This is another example, and this looks like with no septations, just a little bit of calcification. You see calcification in the wall. This also points towards a mucinocystic neoplasm. This patient also happened to be a woman. And this was the specimen, as you can see over here. Characteristic of a mucinous cystic neoplasm is the mucinous epithelium, but an ovarian-like stroma surrounding this lesion. It's interesting because if you look at this in the microscope, it looks identical to a mucinous neoplasm of the ovary. And in fact, it is felt that this is a remnant of the gonad as it travels from the metanephros down into the pelvis. How do we manage mucinous cystic neoplasms? Well, the Sendai consensus about 20 years ago said we should resect all of them. And why? Well, because they occur in middle-aged women, so their life expectancy is high. So even if we don't feel there is a cancer based on certain characteristics, we would be obligated to follow this for decades. And then furthermore, they're in the body and tail of the pancreas, so resection is far less onerous than doing a Whipple for a lesion in the head of the pancreas. And nowadays, we can do a lot of these minimally invasive. The most common operation required for this is a distal pancreatectomy, spleen preservation whenever possible. Why? Because this is not a tumor that tends to go to the lymph nodes. So the lymphadenectomy is not even necessary. As I mentioned, ideal for laparoscopic or robotic distal pancreatectomy, but it's very important to remove the specimen intact and not to rupture it and spill this mucus, which potentially can lead to dissemination. In very rare cases, nucleation would be feasible. There's some recent data showing that in older or unfit patients, observation is perfectly appropriate, as would be clinically savvy. And there's data showing that only tumors that are more than 4 centimeters or have an elevated serum CA-99 or presence of nodules are associated with malignancy. So you could potentially follow this even in a younger patient who has other comorbidities where you would not want to recommend a distal pancreatectomy. But keep in mind, again, this is a lesion that has potential for malignancy. Now let's talk very briefly about cystic endocrine tumors of the pancreas. Here you're seeing 4 different cystic lesions of the pancreas. They all happen to be in the body and tail. You look at this, you say, oh, this could be like a mucinous cystic neoplasm. Looks very similar to the ones I was showing you. You can say this looks like potentially a cerocystoadenoma. This looks a little odd because it has all this enhancement, and this one also enhancement as well. Well, all these 4 are cystic neuroendocrine tumors. Here's another case. This is an interesting clinical presentation because this patient was having profuse diarrhea. And because of this, he was scheduled to have a colonoscopy. They could not do the colonoscopy, and they did a CT colonography, which showed this large cystic mass with calcifications in the head of the pancreas. And it became apparent that his diarrhea was due to obstruction of the pancreatic duct. In fact, his diarrhea resolved with enzymes, and eventually he underwent an operation. You can see the specimen here, and this is a cystic neuroendocrine tumor. So what do we know? Well, currently, 1 of every 14 resected cystic tumors of the pancreas, so not of all cystic tumors that you see, but the ones that end up needing an operation are a cystic pancreatic endocrine tumor. Between 10 and 17% of endocrine tumors are cystic. Most of them are incidentally discovered. The vast majority are non-functional. They're more likely to be associated with MEN1. So this is something that the clinician should see. I see a cystic lesion. It turns out that the biopsy shows it's a neuroendocrine. I should suspect the possibility of MEN1 and pursue it by just at least checking calcium or PTH. EU aspiration is very, very good to make this diagnosis. They typically have a low or very low carcinoembryonic antigen in the fluid, and the diagnostic yield for cytology is very high. And the survival for these patients is excellent. The long-term survival is more than 85%. So now we come to the main problem. And the main problem is IPMN. And why is it the main problem? Well, for a number of reasons, but the first one is that this is the vast majority of cystic lesions that are seen by a clinician, by a gastroenterologist, a surgeon, or an internist are going to be IPMNs. What is IPMN? It's a proliferation of the mucinous cells of the pancreatic duct. It can affect the main duct, branches, or both. This mucin produces cystic dilations of the ductal system from the overproduction of mucus. The mean age of diagnosis is 66. It affects equally men and women, at least in this part of the world. In Asia, it's more predominant in men. And this tumor can cause a way big variety of symptoms. It can cause abdominal pain. It can cause pancreatitis. It can cause jaundice. It can cause diarrhea. It can cause diabetes. But the majority of patients, in fact, have no symptoms, and this is an incidental finding. The first thing you need to know about IPMNs is they come in two different broad types. The branch duct IPMN, so you can see it depicted here in this cartoon. You see the main pancreatic duct, and then from a branch, you see this that looks like a cluster of grapes, or it can feign the main pancreatic duct. And this matters a lot for the reasons I will tell you right now, because the risk of malignancy is very, very different. This is the classical appearance of a papilla bulging and excluding mucus. This was described, 30 years ago and was pathognomonic, really, of a main duct IPMN. We see this very rarely because the majority of IPMNs that we currently see are branch duct IPMNs, and they do not produce that much mucus to see this. But if you see this as an endoscopist, you can make your diagnosis confidently of an IPMN, very likely main duct IPMN. Here you see the pancreatography of this, and you can see that there's filling defects within the pancreatic duct. These filling defects could be actually tumors within it, or it can be mucus that is so dense that it doesn't allow the contrast to fill the duct well. Here you see a nice CT reformatted, and you can see a branch duct IPMN, but also dilation of the main pancreatic duct. So this is probably a combined type, branch and main duct, or it could be a branch duct that is producing a lot of mucus and therefore dilating this. And here you see an endoscopic ultrasound, a nice image of a nodule within this pancreatic duct. Here's an example of a surgical specimen. This patient actually had presented with jaundice. You can see a big cystic cavity here with some nodules, and the pancreatic duct was dilated throughout the pancreas. That doesn't mean that the patient needs to have a total pancreatectomy, because the tumor is actually here, but this dilation of the duct is the reflection of the thick mucus that is causing obstruction. So main duct, or combined, or also called mixed IPMN, there is a clear thinking and evidence that there's progression from adenoma to carcinoma, often seen within the same tumor. So this is very similar to a villous adenoma of the rectum or the colon, where you can take a biopsy that just shows adenoma, but further biopsies or a surgical resection will show that they could also be carcinoma. At the time of diagnosis, about 42% of these patients have invasive cancer, another 18% have carcinoma in situ. So that is 60% risk of malignancy at the time of diagnosis. Evidence that there's an evolution from adenoma to carcinoma is even seen in simple things like an age differential between those that have invasive cancer and carcinoma in situ. It's 6 years, so we think it takes about 6 years for this to transform. And they're also more likely to have symptoms like jaundice, diabetes, abdominal pain, or have a solid component within them. Main duct or combined IPMN surgery is a treatment of choice. Excellent survival post-resection, even for invasive cancer, as I will show you. Because of the intraductal spread, it's important that the surgeon keeps this in mind and ensures that there's negative margins at the time of the operation by frozen section. And the risk of recurrence in the remaining pancreas, even if the margin is negative, is about 10%. In these two graphs, you can see progression-free survival comparing invasive IPMN here in blue versus invasive ductal adenocarcinoma in patients who have no lymph node metastasis. And as you can see here, the 5-year survival for this is more than 60%, whereas for pancreatic cancer is more in the range of 10 or 15%. And even for patients who have positive lymph nodes, the survival is better for an IPMN with invasive carcinoma, as you can see in this graph. So this is a little bit like pancreatic cancer light. Of course, there's nothing light of having a 40% chance of dying from your cancer, but it's certainly better than the usual invasive ductal adenocarcinoma. And then we come to the main problem, which is branch duct IPMN. And why is it the main problem? Well, because it outnumbers main duct IPMN by 100 to 1 at least. So main duct IPMNs are actually rare, but branch ducts, they come every day to knocking at the door for a consultation. Very often an incidental finding, is by far the most likely diagnosis when a small cyst is seen on CT or MRI done for other reasons. Can be multifocal and up to 45%, and much less risk of malignancy. In fact, the majority of those we think will never progress. Here's an example. As you can see here, there's this patient actually had just an increased alkaline phosphatase. Or primary care doctor said, well, maybe it's got gallstones, so they did an ultrasound. The ultrasound showed a small cyst. the cyst prompted the CAT scan. You can see the small cyst here, and you can see here in the MRI a typical branch duct IPMN. But other patients will have multiple, like this one has 1, 2, 3, 4, 5, 6, perhaps 7 of these branch duct IPMNs. What are the problems with branch duct IPMN? First of all, it is a known precursor of pancreatic cancer. And although we don't have firm data, it is felt that between 10 and 25% of all pancreatic cancers either arise or occur in association with a branch duct IPMN. So if pancreatic cancer will be the second most common cause of cancer death in the United States by 2030, well, we need to do something, because here we may have an opportunity to identify it early. On the other hand, pancreatic cancer, thankfully, is not that common. It's not like colon cancer or breast cancer or prostate cancer, but it's still a very lethal disease. And we are identifying this more and more because imaging has gotten so much better. So we didn't know what to do with this. We initially were operating on many of these because we felt we were preventing pancreatic cancer, and then have come a series of recommendations and guidelines. The first one was the Sendai recommendations that said that observation for asymptomatic patients with a branch duct IPMN of less than 3 centimeters that had no nodules, no main duct dilation, was appropriate. And many studies have shown these guidelines are safe. But also, if we go ahead and operate on anybody who's doesn't have these exemptions, we're going to find that the majority of resected branch duct IPMNs are benign. This came to a second iteration of these International Association of Pancreatology guidelines called the Fukuoka guidelines. And it stratified these lesions further by creating 2 categories, one called high-risk stigmata and another one called worrisome features. High-risk stigmata is if a patient has jaundice or has an enhancing solid component or a main pancreatic duct of more than 10 millimeters. All of these patients should strongly be considered for resection. What are worrisome features? I think many of you may be familiar, but I will read them here. A cyst that is more than 3 centimeters is worrisome. A rapid growth, more than 5 millimeters in 2 years. A thickened or enhancing cyst wall. A main duct between 5 and 9 millimeters. A non-enhancing mural nodule. An abrupt change in the main pancreatic duct, lymphadenopathy, or an elevated C99. Any of these is considered worrisome features. And whenever you have a patient who has a worrisome feature, you should refer this patient for an endoscopic ultrasound to better define things, as I will show right now, and hopefully get cytology and perhaps molecular analysis. If a nodule is confirmed to be present, or the cytology is suspicious, or there's involvement of the main pancreatic duct, then resection is recommended. And having multiple worrisome features is something that should raise even more concern. In this graph here, you can see it's a study that we did here at Mass General, 810 patients. And if you see you have no worrisome features, well, the risk of having invasive cancer is essentially nil. However, you can still have high-grade dysplasia in a small percent of cases. You have one worrisome feature, that risk is 25%, but then it increases in a stepwise fashion with the number of worrisome features. And here's high-risk stigmata. Any high-risk stigmata gives you a risk of 63%. And what I want to show here is if you have 3 worrisome features, it's equivalent to having 1 high-risk stigmata. So the majority of patients will not have not even 1 worrisome feature. So what do we do with these patients? And this is the last part of the algorithm of the Kyoto guidelines that were just published last year. So you have no worrisome features. You're going to do surveillance on this patient. Then you're going to do the surveillance based on the size of the largest cyst. If that cyst is under 20 millimeters, and I'll tell you right now, that's the vast majority of patients, you should always repeat imaging at 6 months. Why? You don't know at what time point you're seeing the cyst, and things could grow and could grow fast. So if at 6 months it is unchanged, that's a good thing. And the vast majority of patients will be unchanged. And if that's unchanged, then every 18 months, if there's stability of the cyst. If you do see progression, then you should send that patient to get endoscopic ultrasound and potentially resection if there's any more concerning features. But if there is no progression, and there's no progression for 5 years, and this is the main change in the Kyoto guidelines that say that if there's no progression and the cyst is less than 20 millimeters, although I will tell you there's a little bit of controversy on this, then you can stop surveillance at 5 years. but there is, as I mentioned, some controversy, and so I will recommend to continue surveillance. If your cyst is between 20 and 30 millimeters, again, 6 months, then every 12 months in sort of the same plan. If it's more than 30 millimeters, you've already done probably an endoscopic ultrasound, because that by itself is a worrisome features. You need to follow these patients very, very closely. Warning for all of you, surveillance with imaging is indeed very good to identify progression in branch duct IPMNs and its transformation to a malignant lesion. However, we clinicians and the patients, is very important, need to be aware that surveillance is not adequate to identify concomitant or de novo pancreatic cancer. And the problem is that the risk of pancreatic cancer, regular pancreatic cancer, appears to be increased in patients with branch duct IPMN. So when is it safe to discontinue surveillance? I'm going to go a little bit quickly on these slides because we're running out of time. But we looked at cysts that were under 1.5 centimeters, and we looked at our experience here together with Verona, Italy, which has a lot of big experience. And after 3 years of surveillance, if there's no progression, the likelihood of progression to malignancy is very low. But again, keep in mind that there's still going to be a risk of regular pancreatic cancer. But the surveillance we're offering to patients is not designed to identify this. There's another paper that just came out in gastroenterology last year, and this looked at a very large number of patients. And after making careful observations, although with a sort of limited follow-up, because the median was only 53 months, in patients age 75 or older with cysts less than 3 centimeters, the standardized incidence ratio for pancreatic cancer is only 1.12, so it's not significantly different than the rest of the population. And so you could make a case that after 5 years, you could stop surveillance in patients over age 75. In patients over age 65, you can do that only for cysts that are less than 1.5 centimeters. Caveat is that the follow-up has not been that robust in all of these. This is in contradiction to what the American Gastroenterological Association guidelines did almost 10 years ago, and that I will just stop here and say you should not follow these guidelines, because these guidelines say to stop all surveillance regardless of whatever at 5 years, and only proceed to surgery if you have 2 worrisome features or more. And you can see here you would be missing a lot of cancers. So briefly, how useful is endoscopic ultrasound in the evaluation of cystic neoplasms of the pancreas? Very, very useful. I think it's one of the major contributions of endoscopic ultrasound in pancreas. It gives you finer morphologic detail, sometimes precise enough to make a diagnosis, allows you to aspirate the fluid to look for markers like CA, amylase, DAS1. It also allows you to make DNA analysis, as we will see. And then, of course, you can biopsy the wall or do cytology of the aspirated fluid. And all this helps in making the diagnosis, but not always, unfortunately. Here you see an example of a CAT scan. The cyst looks very tame and very timid, and yet by endoscopic ultrasound, it appears that it may have a nodule. On the other hand, not everything that looks like a nodule, here the endoscopist even put the name here, mirror nodule. This is not a nodule. This is actually a glob of mucin within this. There's ways to differentiate this by endoscopic ultrasound, looking at flow. CA in cyst fluid has been around for almost 20 years, and an elevated CA, more than 192, is present in 2/3 of IPMNs and MCNs. It is very low in serous adenomas and cystic neuroendocrine tumors, so this is helpful. However, IPMNs and MCNs can have low and even very low CA and harbor malignancy. So it does not allow you to make a diagnosis of who has malignancy or not. And some pseudocysts and other benign cystic lesions can have an elevated CA, so it's not a perfect marker. Genetic analysis, a lot of progress has been made. KRAS mutations are found in about half of all IPMNs and mucinocystic neoplasms. GNAS mutations are found only in IPMNs. So if you aspirate the fluid and there's a GNAS mutation, you can tell the patient you definitively have an IPMN. However, the presence of a KRAS or a GNAS mutation does not correlate with the degree of dysplasia. As I said, a lot of progress has been made. There's now various commercial platforms available using next generation sequencing. Pancreas-seq published their data in 2023 in gastroenterology, appears to be very accurate to identify the different types of pancreatic cystic neoplasms and non-neoplastic cysts. It also seems very promising to identify advanced neoplasia. I think a little bit more data is needed for this. What is the problem? Well, this requires an endoscopic ultrasound. Are you going to do an endoscopic ultrasound on your patient every year for the rest of their lives? Probably not. Cytology can also be useful, but keep in mind that the positive predictive value is only 60%. So you can have a cancer within that cyst and the cytology be negative or reported as negative or just atypical or non-specific. And so it is not, unfortunately, the same thing as biopsying a solid mass in the pancreas where the accuracy is very, very high. So where do I see the future? I see the future in a blood-based test. And I see the future as a test that can be done as often as you want, every 3 months, every 6 months, every year. And then if that test comes back abnormal, then proceed with further workup with imaging. Because it's also unrealistic that we're going to be doing MRIs on every single patient with a pancreatic cyst for the rest of their lives. This is costly. This creates a lot of anxiety. And this will also identify other things that perhaps we don't want to identify because they're going to be a sort of concern. We're working on this and looking at extracellular vesicles. We're now able to identify patients with invasive IPMN and differentiate them from the low-grade IPMNs. However, this is not good enough. We don't want to wait until our patient has invasive cancer within the IPMN. We want to identify patients who have high-grade dysplasia. We're working on this, and hopefully in the future, we're going to have a test that's going to be good. So in conclusion, take home this message. The vast majority of presumed IPMNs will never need surgery. And small pancreatic cysts, which may or may not be IPMNs, because we don't have proof of that, do not appear to require lifelong follow-up. Whether it's going to be 3 years or 5 years, whether it's going to be age-adjusted, certainly in elderly patients with a small cyst, after 3 or 5 years of surveillance, there's been no change. You can tell the patient that the likelihood that they will have pancreatic cancer arising from this cyst is no different than the risk of a regular person having pancreatic cancer. But you always tell them, but you can still do that because you can still develop regular pancreatic cancer. By the way, the risk of any of us, myself and everybody else who's listening to this, of developing pancreatic cancer over your lifetime is 1%. So it's not zero, right? Everyone is at risk, and unfortunately, it's still a disease that we diagnose late. So if you have an IPMN, take home the message. Yes, cancer can arise within the IPMN. Surveillance will probably pick that up if you do it on a regular basis. But cancer can also rise elsewhere in the pancreas and be independent of the IPMN, and that is not going to be picked up by surveillance. Larger IPMNs do need long-term follow-up. Criteria for surgical resection and objectives vary, and the guidelines, in my opinion, need to be adjusted for patient age and preference. It makes silly to be following 90-year-olds who have, a 1.8 centimeter pancreatic cyst. Of course, people are now living longer, and you need to discuss with the patient, but also be mindful of the resources that we have. And the final message is current guidelines are good. You want a good guideline, look at the Kyoto guideline. You can download it for free. It's there, and it will be a very good parameter to say, I'm doing what I think is safe. Is it perfect? It is not perfect. Could it be simplified? Yes, it could be simplified. Is it going to miss some cancers? Yes, it's going to miss cancers, but not cancers typically arising within your IPMN. And again, from my perspective, better tests, ideally non-invasive, are needed to deliver more precise care for these patients. Thank you very much for your attention.